Supernish, you want to raise your hand? Okay, they're right over here. Yeah, thank you. Thank you for being here. There's also K2, which is right next to Supernish. Oh, there's K2. Okay, K2. They do medical research, and they do have a Parkinson's trial going on, so you might want to talk to them about doing clinical trials through them. You'll be treated with respect and courtesy and caring by their staff. So don't think going through a clinical trial means that you're a guinea pig. You're not. Well, you are in a way, but they do it very professionally. And without these clinical trials, we wouldn't have the medications that we have today. So just think about that, because there's a lot of companies that are here today that have new drugs on the market because it went through clinical trials to begin with. Okay? And I just got some breaking news I need to tell you about. I heard about this. There was a truckload of Vicks Vapor Rub that overturned on I-95 this morning, but fortunately there was no congestion. You like that one, huh? See, I've told you all in the past that in my retirement, I'm going to be a stand-up comedian, you know? But I had to learn clean jokes for today. So a lot of the jokes I tell are not very clean. So, but when I see, because they make all the money, all the comedians that do off-color jokes, they make the most money, so, yeah. So I wanted to talk about Advent Neuroscience Institute and Dr. Lotia. Dr. Lotia is been a great influence to the Parkinson's Alliance. He sees a lot of our people that are in our support groups, and they have an entire floor dedicated to movement disorders with a staff of neurologists, therapists, and even a dietitian. And you know how much we love dietitians, right? Because they tell us what and what not to eat. And I don't think if Josh was here today, he'd be real happy about all those pastries in the back. But that's why we didn't invite him today, because we wanted to have the pastries. So Dr. Lotia is the movement disorder director of the State-of-the-Art Institute and Advent. He is accomplished his 2-year movement disorder fellowship at Baylor College of Medicine. Then he left Houston, Texas for University of Arkansas, where he served as a professor and neurology resident program director before he came to Florida. And he's been with Advent since 2021, and they are very lucky to have him, along with the other people in their group. So, Dr. Lotia, come on down. Here he is. I'll move my stool out of the way because I'm too short. So.
This is awesome, thank you.
Okay.
Good morning, everyone. Well, thank you so much for having me here. It's a true pleasure. And first of all, I want to start with thanking Brevard Parkinson's Alliance for doing this event. We've been doing this for 3 years in Orlando campus, and I know that this is not a small thing to accomplish. We usually take at least 6 months or a year and a lot of hours of my team to set up something like this. And it's amazing that they've done this with so much grace and opportunity for a lot of you to learn. So thank you all for doing this. I really appreciate them. And thank you for having me. Actually, when I joined here in 2022, I remember within my first 4 months, I met with Barbara, and her first request was, when are you coming to Brevard? I mean, you know, that's the passion she had, and we spoke about that, you know, right now we want to establish care within Orlando, which was lacking, but we definitely would love to partner with them to help a lot of patients here. And I've talked to many of you. I see a lot of familiar faces. Yes, at this point we may not be here physically, but we certainly can do a lot virtually, and we can certainly help and partner in many different ways, especially something like this. Patient education is a big thing for me. I believe knowledge is power, and I want you to be aware of what you're dealing with so you can actually have a better quality of life as the journey begins. With that, I'll start with my discussion. I'm supposed to talk about a topic that's actually very close to me. This is about non-motor symptoms. So the title is Parkinson's disease, more than a tremor. And so we'll talk about different non-motor symptoms and see how best to live with them. So these are the objectives. So we'll identify some non-motor features, understand disease progression and how differently they can present themselves, and then discuss a holistic approach to these different symptoms that people may have. And we'll kind of go through some cases just to kind of bring some relativity to it. So case one, Mr. J, 74-year-old man, diagnosed with Parkinson's 2 years ago, had right-sided resting tremor, shuffling gait, and the softening of the voice, and started on the carbidopa, levodopa, and then they come back and they're like, I am constipated. I think it's a side effect of the medication. All right, so we'll come back to that. Before we dive in, I always like to start with this slide, is Parkinsonism. How many of you have been told that you have Parkinsonism and you're still trying to figure out that whether you have Parkinsonism or Parkinson's disease? Yeah. So very few, which is great that they are doing great in education, but that's often one of the questions is, somebody told me I have Parkinsonism. Does it mean I have Parkinson's disease or something else? So idea is, what is Parkinsonism? Generally, when we say there is Parkinsonism, we are trying to say that somebody has a tremor, balance issues, physical slowness in general. But there can be many, many reasons for that. The biggest cause we think of it is as Parkinson's disease, but there can also be other causes, especially certain medications. Even severe depression sometimes can manifest itself as Parkinsonism. Somebody had a stroke. And then there are other atypical forms, which are progressive neurodegenerative conditions. These are relatively uncommon compared to Parkinson's disease, but they can be present. So Lewy body dementia, multiple system atrophy, and other types of toxic neurodegenerative conditions. But in general, today we're going to focus on Parkinson's disease as an entity. So Parkinson's disease is a second most common progressive neurodegenerative condition. Happens due to the loss of the dopamine-producing neurons in the middle part of the brain. Typical symptoms are bradykinesia, which is a very peculiar type of slowness that people have with Parkinson's, rigidity, a resting tremor, and a postural instability. By show of hands, how many patients or how many of you have tremors? All right, so kind of half of the room, 60%, and that's what we typically see. So one of the reason often people say, hey, look, I don't think I have Parkinson's because I don't have tremors. Well, tremor is not a requirement for you to be diagnosed with Parkinson's. What is required is what we call bradykinesia. So that's why many times when you're going to your offices and your neurologist is doing these tests, that's what we are looking for. What happens is, as you start doing this, in people with Parkinson's, it not only starts getting slower, but also smaller. And that's a very peculiar type of slowness. It's called bradykinesia. And that is a must for someone to have to be diagnosed with Parkinson's. And then 2 out of the 3 symptoms of the rigidity, which is something we feel on your muscle tone, the resting tremor, and a very peculiar type of walking pattern. Either it's a shuffling gait or a slower stride length, or they are just unable to maintain their balance. So these are the features we usually utilize to diagnose somebody with Parkinson's. So again, to date, it's still a very clinical diagnosis. We run some tests like MRI and things like that to rule out other causes. We are not looking into confirm Parkinson's disease by any means by doing that. There are other tests, but we can talk about that at a later time. But just a general overview that I always like to go over. This is another slide that I like to show is, how the idea of Parkinson's is changing. Back in the days, we all thought that, oh, it just happens to those who are old and frail, and that's not true. Parkinson's does affect individuals at a younger age. We have many patients who are in their 20s. My youngest is 24-year-old. But it can affect that. Obviously, age is a bigger risk factor in general, but it can affect younger individuals. It can start just with affecting one side. All they may have is like a twisting, turning of the toe. It's called dystonia, and then it may progress to rest of the symptoms. And then a typical middle stage where there are many who are doing really, really well on the medications. Many of them you see and you're like, do you really have Parkinson's? I don't see any Parkinson's signs. And then they have these typical off and ons as the disease progresses, where when the medications are working, they're looking great and they're doing fine. And then when the meds are not working, that's when they start having the symptoms. And then there is a third kind, which we see more as an advanced stage. So people above 80, in general, they might have these where suddenly it's a very diffuse progression. It starts affecting more of the balance. They may or may not have tremors, but they have very quick cognitive issues, balance issues, and meds may not work on all the symptoms. So again, it presents itself in many, many different ways. That's why we think of Parkinson's as not a single disease as such. It's a syndrome, as we like to call it. Some of us, talk about this as well as to what causes Parkinson's. The idea is that it's due to a toxic protein. We call it as alpha-synuclein. So the image here, you see that's the reverse Mickey Mouse. That's on the left, that's a patient's brain who had otherwise normal, healthy brain, but they obviously died. And then you see that black line, that's the melanin, and that's the neurons that produce the chemical called dopamine. And this is the brain of an individual who had Parkinson's and they pass, and there is loss of this dopamine producing neurons here. If you put that on the electron microscope, you can see again loss of that dopamine producing neurons versus a relatively healthy brain in a healthy individual. And again, why this happens? Because the toxin alpha-synuclein gets transferred to a toxin version and then turns into a Lewy body, which then starts affecting these neurons that produce the chemical dopamine, and then patient starts having symptom in that regard. This is one of the most accepted progression as how we think disease progresses. In general, Parkinson's tends to progress slowly. Usually when I say slow, it's over the years or decades and many times. And that's how we think right now is, the Lewy body enters the brain from the outside and then affects the brain stem first, the middle part of the brain, and then slowly and gradually progresses to involve the rest of the brain. And that's how the disease progresses over decades. And we believe that people have had these Lewy bodies for many, many years before they actually start showing symptoms of Parkinson's as such. So if I were to plot this on a graph, this is how it would look. So many times people have what we call these as premotor symptoms. Premotor symptoms are, which is not a tremor, not a slowness, but it's more like a, either constipation or REM behavior disorder or lack of sense of smell, and then, or sometimes they even may have mood issues, and after some time they start having the tremor and the bradykinesia, etc. That's typically when they are diagnosed, but then as you see that as the disease progresses, some other symptoms may come on. So we'll talk about some of this today as we kind of progress through this. Recent discussion is that maybe there is a different way how it actually begins and progresses. Now there are proof of concepts where we believe that, how everybody progresses differently, where some people actually have Parkinson's that starts in their body first, meaning they actually have constipation for years and years before they start developing Parkinson's. And then the other side is the brain first, where they initially may have lack of sense of smell or REM behavior disorder, and then progression that way. And these two set of patients do tend to progress differently. In general, there is a much later cognitive issue in this group versus earlier cognitive problems in this group, and then they tend to have more tremors, and this group tends to have more balance issues, and so on and so forth. So there are some discussion, and this is what has brought us to the whole discussion about the environmental factors, because the body first, meaning constipation. So the food that we eat has a bigger role. That's why we talk about gut-brain hypothesis. And the brain first is things that we inhale that's in our environment. And that's where a lot of the focus is going on as to how people get Parkinson's these days. All right, so when I say the non-motor symptoms, again, clarifying, non-motor means things that are not tremors, not slowness, not stiffness, or balance issues. These are other symptoms that people may feel or have, but often are not looked upon. So generally you think of the body, Parkinson's affects many different systems in the body. It affects the autonomic nervous system, we'll talk about that. It causes neuropsychiatric manifestations. It also causes other bodily dysfunction and skin changes and things like that. So we'll certainly go through each of these as we go through that. Question comes is, how common are these non-motor symptoms? In general, we believe it affects 80 to 100%. So it's a very high prevalence. In general, when people start having these fluctuations where they're off and on, mostly all of them have at least one non-motor symptom. And that could be also just lack of sense of smell or constipation or dream enactment behavior. The idea is that you have to be at least aware of it. It doesn't mean that everybody will get all the non-motor symptoms, but you may have at least one or two. And as we talk about quality of life, it is important to focus on these symptoms as well and identify things that bother you so we can start working on those issues as well. This is just one of the graph. It was one of the Taiwanese studies over 6 years, and they were sort of plotting as to differences in men and women. I know it's kind of looking small for you all, but in general, what we see is things like constipation, the dream enactment behavior, the hyposmia, some mood issues actually come much, much earlier. And then in general, the orthostatic hypotension, the cognitive issues, the hallucinations come as the disease advances. So that's the traditional that we have seen. So coming back to Mr. J, who had constipation, but actually when you started asking more, well, they've had constipation for 5 years, and they used to have what they call consturia, like on a day they would have constipation, and then they would have diarrhea, and then so on and so forth. So many, many times it happens because usually what happens is the gut is not moving as quickly, and there is obviously a stool accumulation, and after that there is a lot more water retention in that area, and the liquid then or soft stool passes around that hard stool. So that's why people have diarrhea, but they still feel impacted. So many, many times then they have to go to the ER. So idea is we kind of talk about that as we work on that. So we'll talk more in detail as we go through. But when I say autonomic dysfunction, it's basically the part of the automatic nervous system that controls a lot of things where you don't have to think. Most of these are reflexes. So think of constipation, the bladder problems, the blood pressure problems, the sexual dysfunction, and then early satiety and also sweat production issues. I've often heard many Parkinson's patients, actually their caregivers tell us that their loved one changed in the way they used to have their odor. So they say like, I could understand that they smell differently now than they used to. So actually there are studies done, and in China they recently published a good paper that looked at training the dogs for early diagnosis just based on the very peculiar smell or odor that many Parkinson's patients have. So again, it affects multiple different systems in our body, as I spoke about. So constipation, again, as I said, it's very, very common. In our opinion, it's one of the prodromal marker. Again, just because somebody has constipation doesn't mean they will develop Parkinson's, but it's the other way. When people have Parkinson's, many times they've had constipation for a few years. So in general, when I'm seeing them the first time, especially for newer diagnosis, we kind of talk about that or ask that question about their bowel movements. And then after that, we kind of talk about that. Yes, these dopaminergic medications can make it worse, but the idea is that unfortunately it's part of the disease, so we obviously have to manage it. The simple things, the routine things are obviously increasing your fiber intake, increasing your water intake, and fluid intake is important. So 64 ounces of total fluid per day is what we recommend. We don't count alcohol in that. So generally water, some juice, caffeine, etc. But in general, 64 ounces of water and of course fiber. Prune juice is a very good way as well. There is one recipe that I actually like. It's called Rancho recipe, which is combination of apple juice, wheat bran, and prune juice together. You mix it, and you have like a couple of tablespoons a day, and that actually helps quite a bit with constipation too. And then again, as you move around, the more you walk, your gut moves, and that helps the constipation. There are a couple of medications, but before we do that, I would at least try, if people can try Miralax and other things, and if that doesn't work, then there are a couple of medications. In general, most people do well as they maintain their high fiber and high fluid diet. One of the other symptoms is overactive bladder. Again, it's very common depending on what you look at the studies wise, but 30 to 85% of people may experience this, tend to be more common in men and women. Typical symptoms are that they have to go often at night, which can disrupt the sleep as you can imagine. Also have to go often and have to go urgent. So urgency, frequency. And then there is also a sense of incomplete emptying, that they go and they're like, I don't think I finished it, I have to go back again. So these are some of the common symptoms. And then you add that, like, okay, you're slow. You have urgency, but you're slow, so you cannot make it to the bathroom. So that's what leads to what we call urge incontinence. So those are some of the symptoms. Obviously that can affect in many ways. It becomes difficult for planning your day. I have many patients who feel very anxious to go out because of this issue. Obviously it affects the sleep. It increases risk of fall. Now certainly you have an urgency, you're not going to be able to make it, and obviously that leads to more falls as well. So there are many challenges there. Again, it's because of that part of the automatic nervous system that is supposed to send the exact signal to the bladder as to when it should contract to give that sensation to the brain. That part has just become overactive. So even a drop of urine makes it spasm out very quickly, and then those muscles that are supposed to keep that control are not working as well. So it's a combination of those two things that causes more challenges. So again, generally how do we manage it? Again, we screen for that, and then I at least want them to see a urologist. Especially for men, I want to make sure they don't have any prostate issues, because sometimes the symptoms can be similar. In women, there can be some urogynecological issues, so we get them screened for urogynecological conditions. Once they say, you know what, there are no other issues, we sort of then think about some of the simple things. So behavioral therapy, so simple things again, trying to minimize the fluid intake in the later part of the day, trying to minimize caffeine in the latter part of the day, actually planning urine breaks. So every 2 hours or something, you want to use the restroom, that way it keeps itself that way. So a lot of those simple things can certainly help things out. But there is also a very good pelvic rehab floor program. So a lot of physical therapies are expert in that, and I think that does a fantastic job. So I'll often tell my rehab team, especially if they see women, to screen for pelvic floor dysfunction, because often that's a challenge. And once we do that, and with the rehab, there is obviously a good recovery. Couple of medications are there, the tamsulosin, the mirabegron. Tamsulosin is good. Mirabegron can be expensive sometimes, and then you have to watch for the higher blood pressure when you put them on that. What I've liked otherwise also is that Botox injection. Believe it or not, Botox around the bladder muscles. It's not injecting the bladder, it's the muscles around or inside of that. So generally the urologist does that. The idea is that this muscle is hyperactive, so we want to try and partially relax it. And for many patients it does well. So between 3 to 6 months of benefit that they can get from that as well. So fortunately, we do have a neurourologist within our group, so usually I refer patients out to them, and that does a good job. And then there are some neuromodulation, some good data coming for the tibial nerve stimulation. What that means is we stimulate one of the nerve here in the leg, and then that takes the signal back to the spine and kind of helps with that as well. And as the disease progresses, in some people, we may have to resort to straight cat, but we're trying to not go there. So if you do these interventions early on, that can be somewhat of a benefit. Orthostatic hypotension, basically what that means is there is a drop in the blood pressure as you stand up. In general, there is a gravity pulling the blood when we all stand up, but there are automatic mechanisms to correct that, to compress those veins so that you can get the blood-brain back to the brain. However, in people with Parkinson's, that system is affected, and therefore they have a lot of issues with orthostatic hypotension. Generally, it's again much later, and it can be seen in more advanced patients. However, we have many patients who have had diabetes, and diabetes can also cause something like this. So we have to be mindful of that and try to treat it. And there are many different phases when people have it. Some people have the orthostatic hypotension right away within first few seconds, but then it goes away. And some people have it otherwise. Like usually they don't feel dizzy right away, but after standing for a few minutes, they start feeling dizzy, and then they have to sit back down. So there is what we call delayed hypotension, and some who has immediately. And we talk about how to manage that. Generally, the compression stockings are your best friends. And not those ones that just go till ankle. You want to go all the way up to the thigh. And yes, for the men, the same thing. But there are some good designer stockings available if you want to look into that. Sometimes we've used abdominal binders, that can help as well. This is when I become their favorite doctor, because I tell them to add more salt. So enjoy those pretzels and French fries that your cardiologist told them not to do, but we try to talk about adding all that now. If those don't work, then there are a couple of medications that artificially increase the blood pressure. And then there was, about 10 years ago, medication that was approved specifically for this. It's called droxidopa, especially for neurogenic orthostatic hypotension. So again, we have to just titrate that up. And the study showed good benefits, at least in controlling the symptoms. It may not necessarily correct all the blood pressure, but it can at least help with the symptoms of dizziness that people get from that. So again, that's how many people can be benefited. So when people are falling or they tell us, hey, I feel very tired after I take my medication, one of the first things we ask them to do is check the blood pressure, because many times it's that low blood pressure that could be contributing to some of this. So we always look into that as well. So many times when people come to our clinic, we ask them to check the sitting blood pressure and standing blood pressure, because we really want to see where the drop is. All right, we'll move on to the next part. Case 2, Mrs. D, 86-year-old, diagnosed with Parkinson's about 9 years ago, and now the husband thinks that she's become more socially withdrawn. So that's another major issue, right? And I know we're going to have an excellent discussion about some mood disorders later in the afternoon, so I won't necessarily dive too deep into this, but again, these are very common. Unfortunately, anxiety, depression, depending on what studies you look at, 40 to 70% of people with Parkinson's get some sort of a mood disorder, whether it is anxiety, depression. I find it more challenging to treat apathy. Many times people, they just feel like, oh, they're losing motivation. They're not as motivated as they used to be. And that's something very, and this is where such opportunities are amazing, because this is where you come in a group and then try to motivate each other and work towards a better goal. Cognitive impairment, of course, there is subjective cognitive decline. People feel like I'm not as sharp as used to be, but then there is also what we call mild cognitive impairment, and then in some cases, Parkinson's disease dementia can happen as well. And psychosis is not just the hallucinations, but some people can become paranoid. They also have impulse control disorder as well, and we'll talk about some of these things as well. So as I said, depression can affect up to 60% of patients. And again, we definitely screen patients for the depression. And I know we're going to talk about some of this with my colleagues, so I don't want to necessarily go too deep into this. Other part is about the cognitive complaints. So this is the tendency. There is some good news in this. Back in the days, people thought that when you have Parkinson's, you're automatically going to get dementia. That's not true. This is different than the Alzheimer's disease. Many people have early onset where they feel like they have cognitive blunting, they are processing things slowly, and those are the early symptoms. Many times what happens is as you start treating them, then they actually start feeling better, that they cognitively feel better, they feel they're back to their initial sharpness. But then again, as the disease progresses, some of the symptoms start coming again. And that's the variance that we are seeing there is when it's just Parkinson's disease and dementia related to that, that tends to be a very slow progression. And very rarely, like towards the latter part, that they have more changes. So typical symptoms these patients have are they have trouble multitasking, trouble paying attention, and as I said, the processing speed is slower. So how it can affect you is, driving can be a challenge, or if you're reaching a furniture, that can be a challenge because of the visual spatial planning can be a challenge. But what we're seeing also is, this sort of the idea of dual pathology. At this point, we are also wondering how many of these patients actually also develop Alzheimer's. And that's what we are seeing, right? In general, there is a big risk of developing dementia or Alzheimer's type of dementia in people above 80. So even those who we thought had just the Lewy body pathology or Lewy body toxins, we actually found the toxins that we also see in Alzheimer's dementia. So many times it happens that they may have the two conditions together. So we also screen for that, and we talk about how to manage that differently as well. So again, keeping an eye on some of these symptoms becomes important. A lot of things have been looked at in the randomized controlled trials, including cognitive behavioral therapy, the speech therapy, the TMS, etc. But overall, the speech therapy is definitely helpful. So somebody who is in early issues where they have the speech difficulties, I definitely refer them to our speech therapist, and they work with them very closely to help improve some of that cognition and some planning and processing, etc. There are, in terms of medications, there are not many. The same medications that we have are the ones we use for Alzheimer's dementia. We have a little bit more data on one of the medication called rivastigmine. So rivastigmine does a good job in initial stages. So we usually think of that in treating in mild to moderate cases of Parkinson's disease related cognitive issues. And then for moderate to severe, we also use the memantine, which is something similar that is used for people in Alzheimer's. There are some trials coming along, so we are hoping that that'll help improve the landscape in that direction. Now, I know this can be a scary thing, the psychosis in Parkinson's, and I want to make sure people understand that. So hallucinations can happen at many stages. Remember, we talked about the dream enactment behavior, or RBD. Many patients have lived with RBD or dream enactment behavior for many years. And many times when they wake up in the middle of the night, they actually have hallucinations just at night when they wake up in the middle. And that is different. Versus as the disease progresses, they have more cognitive changes, and they tend to have more hallucinations during the daytime when they're awake actually. And that's what we usually see in the latter part of the disease. So in general, when we say this, it's a visual hallucination. They usually don't have as much auditory hallucinations, but they can have them, especially if they have a hearing loss. But the paranoia also becomes a challenge. They start getting too worried too quickly about a lot of things, and that becomes a much more challenge for their loved ones as well. So again, the risk factors are advanced age. So when people get Parkinson's as an advanced age, and as it progresses in some individuals, that can be a challenge. If they have underlying cognitive impairment from other reasons, if they had a stroke, or as I said, if they have Alzheimer's dementia, then obviously it can make it more difficult. If they have a concomitant depression, again, that's a big risk. So that's why treating depression becomes important as well. Or they're on medication. Sometimes they're on too high of a dose of the Parkinson's medications, especially with those who have cognitive impairment, and that can also cause hallucinations. So as scary as it sounds, when I talk to my patients about what hallucinations they have, typically they are seeing some formed images. They sometimes see people that they know, sometimes they see people they don't know. many times it's like a very pleasant experience. They're like, oh, I see those little people there, they're just hanging out, they're not doing much. Sometimes I say hi to them. And sometimes they say, oh, today the visitors did not come. So they kind of make fun out of it. So as long as patients are aware that, hey, it's a hallucination, it's not bothersome, we don't need to treat it. But if it starts causing distress to them or to the loved ones, or they start really acting on them, then that's when we actually start talking about treating them. And again, there are medications really approved for that. One of the ones that we use is the pimavanserin, which has been approved for specifically for Parkinson disease-related psychosis, and so that helps quite a bit. And then sometimes we end up using quetiapine, which is an antipsychotic, but at a very low dose. It's very helpful in people with the hallucinations. One other thing I like to talk about is the impulse control disorder, which is basically, excessive gambling or hypersexuality, or buying things that you really, really don't need. In general, the risk is highest when people are on medication that are dopamine agonists, so like ropinirole, pramipexole, Nupropatch, and apomorphine. Those are the medications that do increase the risk of this. But in general, people with Parkinson's are at slightly increased risk. It's not common, but it's important to be aware of it, especially if you're on those medications, so that people can keep an eye on things. And again, if they have pre-existing cognitive impairment, it also becomes important because it can really creep up to you without even knowing. People have lost their homes or they have been in trouble because of these issues, so it's important to keep an eye on that. The idea is to, once you identify it, if it's the medication, usually you take away the medication and that gets better. And then obviously there is a support system that is needed. And very rarely at this point that I've had to use the antipsychotics. All right. Last one would be the third case about the dream enactment behavior. Same thing we've talked about. So 61-year-old diagnosed with Parkinson's about a year ago. And now the spouse sleeps in a different room after he struck her in his sleep. That's again, unfortunately, common. So sleep disorders are common with lack of sleep, REM behavior disorder. They may also have restless leg syndrome and excessive daytime sleepiness. So REM behavior, as I said, it often happens and typically happens after midnight or more than 2 hours into the sleep, because that's when you go into the REM sleep. What happens is generally that's when we have vivid dreams. The body is supposed to be paralyzed. In general, in people with Parkinson's, they lose that paralysis, so that's why they start acting out those dreams. And that's when it becomes very, very challenging. Again, we treat if it starts to affect the patient. This is one of the symptoms I say that I'm still going to treat you even if the patient is not bothered, but it's bothersome to the spouse. The last thing we want is them sleeping in a different room, so we try to treat it. So there are medications we can try, something as simple as melatonin, and very rarely we've used the low-dose benzodiazepines like clonazepam, and rarely have had to use the quetiapine, but generally they respond very, very well to some of these medications. Other sleep disorders are, again, same thing. It's trouble falling asleep and trouble maintaining sleep. I already mentioned why people may have fragmented sleep from urinary problems, from the mood issues. They may also have sleep apnea, so we certainly want to get them screened for that. But in general, most patients we are able to we are able to minimize the medications that they have to really take for their sleep. Many times it's a lot of lifestyle. So we make lifestyle adjustments, sleep hygiene, and a lot of people actually benefit from that. Sometimes if I have to really use it, I would then use different antidepressants because then they have their benefit of sleep. And I know my colleague will talk about that as well. So in general, there are a lot of these non-motor symptoms that you have to be aware of. Doesn't mean that everybody will get all the symptoms, but being aware is important. There are lots of studies that are coming out that actually show that when you do these different exercises, it not only helps your motor symptoms, but it actually helps non-motor symptoms as well. So people who are exercising 30 minutes a day, 5 days a week, in general tend to have a better sleep quality, better mood, much improved cognitive outcomes. as well as improved constipation, and we also talked about urination. So a lot of these symptoms can actually get better or remain stable if you engage in an active lifestyle, which again, I know our Brevard County does an awesome job keeping people on their toes, especially with the rock steady boxing and other exercises. All right, so this is our summary. Again, it's not a disease of one symptom. There are a lot of other symptoms that people need to be aware of it, and definitely bring up to your doctors. I usually say that I'm one of the few doctors who will actually take the blame for many, many symptoms that have. I actually didn't talk about other things, including pain, skin changes, etc., just in the interest of time, but there are a lot of symptoms that you have to be aware of. I usually say, when in doubt, talk to your neurologist and say, hey, I'm having this. Is this Parkinson's or not? That's always the first question. This is what we have talked about, the AdventHealth Neuroscience Institute. We are in Orlando. The vision was to create that one center for everything, that patients don't have to travel. So we have the multidisciplinary clinic happens twice a month at this point, where you not just see me, but rest of my team with PT, OT, speech, our social work, our nutritionist, and genetic counselor. Our social work does a fantastic job in screening people for a lot of other issues that they may have, and they've built out an amazing support program, which is a brain health program that happens almost on a daily basis, and it's obviously free to all the members. You don't have to be our patients, and it's really, really helpful for people to remain engaged one way or the other. This is why we talk about it, because patients with Parkinson's do need the care for multidisciplinary. So this is one of the examples I use where we say patient is the sun, so keeping patient in the center. Some doctors should be very close, like your neurologist, your family doctor, then the rehab and other teams and psychologists, and the last focus is neurosurgeons and other specialists that you need. And I'm very proud that what we've built over the last 4 years. This is my team. So we have that holistic approach that not only just movement disorder doctors, but neurosurgeons, APPs, our social work, and we have our brain health navigators too. One of them is here. She's our DBS nurse navigator, Miss Hallie. And they make me run like I do. Otherwise, it's not possible. They keep me on time. But I'm very, very thankful that I have this team. And again, thank you all for having me here. I really appreciate you. Any questions? Okay. So I'm going to be here if we have questions.
Yes, I wonder if venous insufficiency is a symptom of Parkinson's in the lower legs.
Is venous insufficiency a symptom of Parkinson's?
What? I'm sorry. Venous insufficiency. Right. Yeah, so that's part of that. So the question was, is venous insufficiency part of Parkinson's? I think it comes back to the same thing. Part of it could be the autonomic dysfunction where the nerves are not working well. So that's why there tends to be pooling of the blood. But, again, that's one of the other reasons where the valves in those venous systems are not working. That's one of the aging issue as well. So generally what we do is I would recommend start with a vascular surgeon, make sure there's no blood clot, there are no other, typically we don't see the varicose veins. We don't see the varicose veins in those patients, in people with Parkinson's, but in general, the leg swelling can also be part of this, especially when you're not walking.
So it's not a common symptom.
Right. Varicose veins are not common symptoms of Parkinson's, yes.
Okay, thank you.
Sure. Yes.
Got one over here.
For sure. So I'm just repeating the question and I'm going to ask you to clarify it. They're asking whether we should start the medication sooner when they're not bothersome, or we should wait for a later part. Are we talking specifically about motor symptoms or non-motor symptoms? Motor symptoms. So that's a very good question because that's a common issue. Is carbidopa, levodopa really toxic to the brain? The idea is it's not. In general, I do recommend starting medications early. The reason behind that is, one, 30 to 40% of people with Parkinson's are not aware of their own problems. So that's one. And then they slowly start losing function without even realizing that they're losing function. And once they realize that they're losing it even more, right? So by holding off, we are not doing anything to the brain. In general, we have a clear understanding that those who we started early, they may have a more side effect overall, but still quality of life is way better in general long term compared to those who wait. Because some of the side effects like fluctuations and dyskinesia, they happen more for the disease progression and not just the medication. And the reason we say that is, and we have that data too, that people who then did not have Parkinson's and still took the levodopa did not develop those fluctuations and the dyskinesias. So it's not just the medication, but as the disease progresses, brain loses capacity not only to produce the dopamine, but to also process the dopamine that is coming from the outside. So it doesn't matter whether you waited for 6 months or 6 years, those complications may come at the time when the disease progresses. Hopefully that explains it. Sure.
Hello, doctor. Would you address the antioxidant glutathione in terms of any mitigation of the symptoms of Parkinson's?
Sure, very good question. So question is about the supplement, the glutathione, especially the antioxidant. So there is a lot of discussion about the progression, and we believe that the mitochondria, which is the energy powerhouse that is involved, and there is inflammation. So in general, if you took anti-inflammatory or medications that will improve the function of the mitochondria, would be helpful in general. However, as of now, we don't have any evidence of any supplements helping with the disease progression. The studies have been done for multiple different supplements. I think one of the bigger reason in that, one is partly we are a little too late, one. Number two, many of these medications do not cross the blood-brain barrier. So even if you took it, it may not be reaching the brain in sufficient amount to actually cause a challenge. Because we knew about Parkinson's for 200 plus years. It took 150 years to come up with the first medication because we just couldn't get the blood passed through, the medication passed through. And even now, we are looking at innovative ways to improving that blood-brain barrier permeability. So it's one of the challenges. So in general, I don't recommend people to be on supplements for Parkinson's for various reasons. One of them is cost. Yes. Okay.
Does the shaking of the head a part of Parkinson?
Shaking of the head. Is shaking of the head part of Parkinson's? So when I hear the word shaking, I think of two things. One is, we call it as a head tremor. And the tremor is basically this rhythmic shaking or like this. So it's like as either they're saying yes, yes, or no, no. In general, that's a head tremor, and that's more associated with essential tremor than Parkinson's. However, there are some patients who develop head bobbing like this, and those are dyskinesias. So people with Parkinson's may have, when they're doing this, generalized head bobbing, and those are dyskinesias. So that's definitely part of Parkinson's disease. So when people say head shaking, we always want them to clarify it. And that's why, again, seeing the neurologist is a good start.
Thank you so much, Dr.
Thank you all. Thank you for having me.
So they mic'd me up, but I don't think they have, do they have it on? Okay. So I feel like a fitness instructor now because I have a mic on me. So 1, 2, 1, 2. Anyway, we're going to take a little break, but first we're going to do some exercise. But before we do the exercise, they say that vivid dreams are part of Parkinson's disease, right? I mean, we've talked about that in groups, about our vivid dreams. And the other night, I told my husband that I had a great dream. I was out shopping at Walmart, and he told me that he had a good dream also. He dreamt that he was with 4 beautiful women. So I smiled and I said, of course, one of them was me, right? He said, no, you were at Walmart. You like that?
It's great, Barb.
Okay, all right. All right, so I want to introduce Adam Rhoads. Adam is a physical therapist with my brain just stopped, Knight's Physical Therapy and Wellness here in Viera. And if you all know Nicole, his counterpart, well, she just had a little girl last week. So, that's why she isn't here with us. But she's here in spirit. She's here inside Adam because Adam is going to get us to do some exercise. And, not only do they do exercise at Knight's Physical Therapy, but they have 3 certified people for POWER, which is Parkinson's Wellness Recovery. So there's just a few physical therapy places here in Brevard County that have the people that are certified for this. So if you have any questions about therapy, you can talk to Adam about that. His information is on our table. Okay? The other thing before we start exercising, how many of you are new and have never been to our support group or anything? Okay. So at our table, our Parkinson's table in the front, we have these really nice Brevard Parkinson's Alliance bags. And when you go shopping in Publix, I want to see you all carrying this. It's a great advertisement for us. But inside the bag, we have a hospital kit that we put together. And inside of here, we have a little booklet about being in the hospital with Parkinson's disease. Because the number one thing is to what? What do you have to, when you're in the hospital, what's important? Medications, yes. So, there is a booklet in here, there's a letter in here to have your doctor sign to say, I have Parkinson's disease, I need to get my medications on time. You have to be an advocate, you have to have an advocate there. I've always offered my services that if you're in the hospital, call me, I'll come in and talk to the staff. Not a problem. But you need to get your medications on time. Also in the bag, I have it looks like a little specimen cup, but it's not. And inside, there are 2 stickers, Viola Life stickers. One goes on the outside of your front door, the other one goes on your refrigerator. And then there's also in here information to fill out with your health insurance, your next of kin, your emergency contacts, everything that you need. And if your paramedics come to your house and they see this sticker, they know to go into your refrigerator in the butter dish and they will find this. They'll look at all your information, make a picture of it, and give that to the ER. So that way you don't have to sit there and go over your whole list of meds and things like that. It's all in here. So that is included in your Parkinson's bag. So make sure you stop at the desk and get one of these bags so you have it. If you have any questions, feel free to ask. We're here for you to give you answers. All right, so Adam.
All right.
Let's get started.
Thank you, Barb. Thank you for introducing me, and also thank you to Dr. Lotia as well. I will reiterate one of the things that he did say. Exercise is very, very important for anybody with Parkinson's disease. 30 minutes of exercise a day is definitely what they recommend, 5 days a week, in order to get your heart pumping and to keep that dopamine flowing so that you can use any available dopamine to you to keep yourself moving. Like he said, it also does help with a variety of other symptoms, and so that's what we're gonna do. Before we do break, we're gonna warm up a little bit and do some exercises. I am gonna do them standing up. I want you all to do them sitting down so that you're nice and safe. Nobody's allowed to fall while they're here. I will warn you though, you're gonna be using your arms and getting into open space, so don't smack your person next to you and blame it on me. Yes, I see you guys. I also see a lot of familiar faces out there, so you better have been doing your homework. I am gonna be watching. All right, the first one we're gonna start with is the power up move. The power up move is designed to help to improve the strength or to keep the strength of your spinal extensor muscles so that we don't get that hunched over posture as we go through Parkinson's. With the power up, what you guys are going to do sitting is lean forward in your chair, and then you're gonna power up and out. Yep, And let's do 10 of those. And I want you guys to count nice and loud with me. 3, 4. You guys can get louder than that.
5,
There we go.
6, 7, 8,
Yep. You guys are all doing great.
9, 10.
Very good. Now, to make my speech therapy friends happy as well, I will say the importance of that counting out loud is very, very important. We want you guys to be nice and loud. We want you to speak with intent. We do not want you yelling and straining your vocal cords. So nice and loud, speak with intent. It is a little bit easier for you to do repetitive tasks like counting than it is to speak a sentence that you're actually thinking about as you're doing it. And so that's why counting can be a very good warm-up exercise for you vocally. Next one, power rock. We're going to rock to weight shift. Weight shift is very, very important for all of our mobility, mainly for walking. We can't take a step if we don't weight shift onto the opposite side. So doing this sitting, what we're going to do is weight shift one way, kick out the opposite leg counterbalance as we're reaching down towards the floor. There's 1, back up. 2, nice and loud for me. 3. Yes, I like it.
4.
Let's stop at 5, and now let's do 5 in the opposite direction.
1,
Yep.
2, 3, 4,
Very good.
5.
You guys are doing excellent. 6 works. We can do extra. I like bonus credit.
She gets the prize.
She does. She gets the A+. All right. The next one is the power twist. The power twist is important for helping to decrease our spinal rigidity as we go through Parkinson's. So with that, we're going to open into a big T position. We're going to turn and clap. Now let's open back up. Now turn and clap the other way. Good. Again. Good. And I already lost count, so let's say 4. 5, 6, 7, 8, 9, and 10. Good. The final one is the power step. All these moves are functional as far as Parkinson's is concerned, but the power step is always the most functional. With this one, what you're going to do sitting there is pick up one leg, bring it out to the side, almost like you're trying to get out of the car, and then bringing it back in. And like the rock, we're going to do 5 to one side and then 5 to the other side. Ready? 1, 2, 3. Yep, very good. 4, 5. And now the other way. 6, 7, 8, 9, and 10. Very good. Good job, everybody.
Thank you, Adam. Thank you. Now, this is a good off time. If any of you need to take your medications, now's the time to do it. And then we're going to take a little break, check out the sponsors here. And while we're talking about sponsors, I want to thank Amneal. They have a new medication now called Crexent. Did I say it right? Crexent? Okay. It is a medication designed to reduce off times. So I just, go and talk to Mac about his medication, and I need you back here on time at 11:20. So go have a nice break.
Why I'm easy. I'm easy like Sunday morning. Why in the world Talking about the time ago. Time ago. Well, I feel her around and she's ready for flow. Oh, Mississippi, she's calling my name. Catfish are jumping and paddle wheel bumping. Black water keep rolling on past just the same. Black water keep on rolling. Mississippi moon, won't you keep on shining on me? Black water keep on rolling. Mississippi moon, won't you keep on shining on me? Black water keep on rolling. Mississippi moon, won't you keep on shining on me? Yeah, keep on shining your light. Gonna make everything great. Mama gonna make everything alright. And I ain't got no worries, 'cause I ain't in no hurry at all. Well, if it rains, I don't care. Don't make no difference to me. Just take that streetcar, let's go into town. Yeah, I like to hear some funky Dixieland and dance a honky tonk. And I'll be buying everybody drinks all around. Mississippi moon, won't you keep on shining on me? Mississippi moon, won't you keep on shining on me? Mississippi moon, won't you keep on shining on me? Keep on shining your light. Gonna make everything gonna make everything alright. And I ain't got no worries, 'cause I ain't in no hurry at all. I'd like to hear some funky Dixieland. Pretty mama, come and take me by the hand. I want a honky tonk, pretty honky tonk, with you all night long. I like